Hello, my name is Michelle Peacock. I'm currently in the MSN Nurse Educator program at Nebraska Methodist College. I'm working alongside my preceptor, Erin Putney. This presentation will cover hemodynamic monitoring device and line management. By the end of this presentation, the student should be able to describe the diagnostic data gained from an arterial line, central line, and pulmonary artery catheter, be able to identify the importance of leveling the transducer at the phlebostatic axis, and apply nursing management of an arterial line, central line, and pulmonary artery catheter. Hemodynamic monitoring is simply data collection and hopefully using the data to make better treatment decisions for our patients. And we can gather the data using different types of devices. Now, while hemodynamics may seem new to you, you have been performing hemodynamic monitoring since the beginning of your nursing school career. You just weren't really aware that you were doing it. So looking at our devices, we have a non-invasive, which would be the blood pressure cuff, looking at the patient's heart rate, and now you guys are learning about telemetry. Minimally invasive would be our arterial line and central line, and then the invasive type would be the pulmonary artery catheter. The first device we're going to discuss is arterial lines, also known as ART lines or A lines. You might notice the change in presentation color. So in the hospital setting, each device we are going to discuss typically has a standardized color assigned to them on the display monitor, and arterial lines are typically displayed as red on the monitor. So what diagnostic data does an arterial line provide us? It gives us continuous arterial blood pressure readings, and blood pressure is a clinical measurement of afterload. So ART line blood pressure is more accurate than a cuff blood pressure reading. And also, when we are titrating medication drips with our critical patients, it's useful to know the second by second blood pressure alterations in response to the medical therapy we are providing the patient. The common sites you might see an ART line are either in the radial or femoral artery. The radial artery is preferred for a couple reasons, but the most important is the risk for infection is less in the radial site compared to the femoral artery. A patient can also be more mobile with a radial ART line, like if they want to be moved to the chair, depending on their condition. But the femoral artery is easier to access in like an emergency event, and that's usually where physicians will place them is in an emergency and we need to get the line in quickly. Some components that we need in order to get an accurate arterial reading. I have an image there that kind of shows you everything that we use. Arterial lines use a pressure measurement system. So we need a pressure bag. There's a fluid bag that goes in the pressure bag. We need a transducer with a three-way stopcock. There's a little flush device that's at the bottom of that. We need pressure tubing. We obviously need the monitor and the pressure cables. And then if the patient has a radial ART line, we use a wrist immobilizer to help protect the ART line and stop the patient from bending at the wrist. This slide is very important to understand. When our patient has an arterial line, we must ensure that the blood pressure reading that we are receiving is accurate. So our physiological pressures are measured relative to atmospheric pressure. Therefore, in order to get an accurate blood pressure reading, we must eliminate the effects of atmospheric pressure on our ART line measurement. So how do we do this? We first have to level our transducer to the phlebostatic axis. The phlebostatic axis is a well-defined landmark for intracardiac pressure. And you can see on this image, the phlebostatic axis is about mid-chest and about at the fourth intercostal space. Once you have leveled your transducer to the phlebostatic axis, we will then zero our line. You should zero the transducer at the beginning of your shift, or if we move the patient, like if we move them to the chair, we should re-zero. Or even if you start to notice abnormalities in your arterial blood pressure readings, that would probably be a good time to re-zero and just make sure that everything is accurate. And then when you are assessing your patient hourly and assessing your arterial line hourly, you should be checking to make sure that the transducer is still level with the phlebostatic access. So what happens if we do not zero our transducer, or we do not keep our transducer level with the phlebostatic access? Unfortunately, there are major practice implications impacting our patients. So if the transducer is higher than our phlebostatic access, the blood pressure will read low. If the transducer is lower than the phlebostatic access, the blood pressure will read higher. Considering how critical our patients are and how many high alert drugs we are administering to the patient, we could cause real harm to the patient if our arterial line is not level or accurate. One way to double check to make sure that, like, yep, my arterial line pressure is correct, is to get a manual blood pressure reading. So like if the patient has a radial art line, you would want to use the other arm to get that blood pressure reading. And the arterial blood pressure and the cuff pressure should be similar. And if they're not, you know that you need to re-level and zero your transducer. How do we as nurses care for arterial lines? Well, first, go back to the slide before. We have to make sure our lines are accurate. I'm not going to go into too much detail here, but our arterial waveform should have a well-defined diacritic notch. And that first image on the left-hand side kind of shows you what a normal arterial waveform should look like, and then what happens when they start getting wonky, and now we're not going to get accurate readings with the over dampened or the under dampened waveform. We also perform a square test once a shift, which indicates if our waveform is still accurate. We do this by flushing our arterial line, and you can see it on that right image. It makes a little bit of a square. Again, we're not going to go into too much detail about that, but just in case you hear a nurse talking about a square test or performing one, you understand what they're doing. We're checking the arterial line waveform accuracy. A big one with arterial lines is a vascular assessment. So you can look at that picture there on the bottom that shows the complications that can arise from the presence of an arterial line. We should be checking our patient's hand or leg if they have a femoral artery art line to ensure that there is enough blood flow. So we should be checking like vascular assessments. We should be checking their color, their cap refill time, the presence of pain, numbness, tingliness in the affected extremity, temperature differences between, let's say, their left hand and their right hand, or inability to move, the left hand or the right hand or the leg. Unfortunately, on my unit, this recently happened to a patient. The patient was intubated, so they really couldn't report to us that something was wrong with their hand. But we started to notice color changes and immobility. So we would ask the patient to squeeze our hands so they could squeeze their right hand, but they couldn't squeeze their left hand. And that's where the arterial line was at. And so when that happened, we notified the physician. We got an ultrasound of their left arm and their left artery, and we found a blood clot. Infection prevention, we want to make sure that we keep our arterial line tubing as closed as possible. So if we have to access the line for a blood draw, we want to make sure our hands are washed before handling the line. We use alcohol wipes and sterile syringes and the male-female caps to keep it closed once we're done using our line. We also want to make sure that that transparent dressing is clean, dry, and intact. A few safety considerations with an arterial line: we never, ever inject medications into an arterial line. It is just for monitoring arterial pressure or blood draws. So we do not inject medication into an arterial line. We also never allow air to enter the arterial line tubing. Again, this would cause an air embolus. Flushing the arterial line. So we flush the art line at least once a shift when we're performing that square test, but we also flush after we draw blood off the line. Flushing the line keeps our line working, but it also helps prevent blood clots from developing inside the catheter. We should discontinue the arterial line when it's no longer indicated, again, to try to prevent complications. Removing an art line is very simple. The one thing to consider, though, is that you do have to hold pressure because this catheter is in an artery. It's going to bleed. So if it's in the wrist, we usually hold about 3 to 5 minutes of pressure. If it's in the groin, the femoral artery is much bigger, so you're going to have to hold a little bit longer, so like 10 to 15 minutes there. And then afterwards, we apply a pressure dressing, and you should be checking for bleeding or the development of a hematoma after you remove an arterial line. The second device we're going to discuss is a central line. So what diagnostic data does a central line provide us? It gives us a central venous pressure, also known as a CVP, and a CVP is a clinical measurement of preload. On a hospital monitor, you will see CVP as a blue waveform. Some common location sites for a central line: left subclavian. We also have the right internal jugular. We also call this a right IJ. And then you can also use a PICC line to get a CVP reading. We prefer the left subclavian. I will tell you that the right IJ is very irritating to patients. It hurts them, like when they're moving their neck. And that dressing is really hard to stay in place. So again, the infection risk is a little bit higher in the neck because we can't keep that area well sealed, especially if you have like a male patient with a beard. This becomes your worst nightmare as a nurse. And then as far as the CVP components, it's the same as the arterial line. So if you have a patient and the doctor wants an art line reading and a CVP, you just have a double lumen set. And so you are leveling and zeroing the transducer at the same time as the art line. So all of this is the exact same as the art line that we just discussed. Okay, some safety considerations with a central line. Infection prevention is huge with central lines. So I want you to take a look at that photograph on the right. The catheter tip of the central line is in the superior vena cava, and it's right above the right atrium. Think about the infection preventions strategies that you've already learned when handling central lines. So good hand hygiene, scrubbing the hub, keeping those green Kuros caps on the ends of the catheter hubs when they're not in use. Only accessing the central line if you need it. Keeping the lines clamped when they're not in use. We do not want this patient getting an infected line that is going right into their heart. Just like an arterial line, we should discontinue a central line as soon as the CVP is no longer needed. Removing the central line is different than the arterial line. It is a sterile process. And again, we're doing this to help prevent infection. But the biggest risk when removing a central line is developing a venous air embolism. The patient should be placed in a supine and flat position during the removal process. We will instruct the patient to take a deep breath in using that Valsalva maneuver while we're removing the catheter. So I'll say, take a deep breath and hold it. And as they're holding, I'll pull the catheter and then I'll tell them that they can breathe. Once we pull it out, we're going to hold pressure on that site for about 5 minutes. And then we're going to apply an occlusive dressing to the site. The patient remains bed rest and as flat as they can tolerate, so less than 30 degrees for at least 30 minutes. If you suspect that there is an air embolism, so the patient is starting to struggle to breathe, developing chest pain, turning cyanotic, we want to place that patient on their left lateral and in a Trendelenburg position and notify the physician. The last device that we're going to discuss is a pulmonary artery catheter. We also know this as a Swan-Ganz or a SWAN. This device is invasive and it sits in the pulmonary artery. Swan-Ganz are not common, and so I'm not going to spend much time discussing them. In my own nursing career, I hadn't seen a Swan-Ganz until about 2 years ago, and I see a Swan-Ganz maybe once every few months. We typically only see them in cardiac patients with right ventricular failure. So what diagnostic data does a Swan-Ganz catheter provide us? It gives us a continuous pulmonary artery pressure. When we inflate the balloon, this is called shooting a wedge, we get a wedge pressure. Some clinical measurements that derive from a Swan-Ganz are stroke volume, left ventricular preload, and a mixed venous oxygen saturation. So this type of data is rarely used in the hospital because most hospitals don't use swans. So this information is more nice to know just in case you happen to see one in the future. Common location sites, very similar to central lines. We may see them on the left subclavian. I commonly see them in the right IJ. I've also seen them in the femoral. And then as far as the catheter components, it's the same as the arterial line and the CVP. So if you have a really sick patient and you have ART line, CVP, and swans, it'll be on a triple lumen set. And again, the level and the zeroing of the transducer is the same as the ART line and the CVP. You do it all at one time. The Swan-Ganz waveform is very unique because the waveform changes based on what part of the heart the catheter is located. So this image shows you how that waveform looks different in different parts of the heart. So when you are caring for a patient with a Swan-Ganz, you have to assess the waveform to make sure that the catheter is sitting in the pulmonary artery and didn't accidentally get pulled into the right ventricle or into the right atrium. Again, this is not something you need to know. This is just nice to know information. So why don't we use Swan-Ganz often? Well, there are a lot of safety issues with the device. The biggest safety risk is when the balloon is inflated in the pulmonary artery. So this image on the left shows how it blocks blood flow to the lungs. The catheter image on the top right is what the balloon looks like when we are inflating it and shooting that wedge. So the safety issue arises if the balloon does not properly deflate, and that can cause a pulmonary artery occlusion. The other safety issue is if the balloon is partially inflated and the nurse doesn't realize it when the swan is being removed. And this would cause rupture of the pulmonary artery as well as damage to that tricuspid valve as it's being pulled out of the heart. The Swan-Ganz should always have the manufacturer's syringe connected to the red line. You can see that bottom image there. The syringe should always be completely empty of any air, and the line should be in a locked position. So it might be hard to see, but you can see that the red line is offset a little bit. This is indicating that it's locked and the balloon cannot be accidentally inflated. Infection prevention is the same as the central line, which we've already discussed. And then as far as who can remove a Swan-Ganz catheter, this should be verified with your hospital policy and procedure. However, the process of actually removing the Swan-Ganz is the same as a central line. So again, sterile, bed rest, and the risk for venous air embolism is the same. This concludes the presentation on hemodynamic monitoring lines and devices. I have my references listed here. If you have any questions at all, please don't hesitate to reach out. Thank you very much.